involved in research. So just a quick introduction. Hello everyone again, I'm Adam Wamsley. I'm a fifth year medical student at TCD, and I'm going to be joined shortly by Mr Kealey, who is the Director of Major Trauma at Royal Victoria Hospital Belfast. He also has interest in complex lower limb and pelvis fracture, as well as total hip replacement, but I think he's going to give you a quick introduction to himself later on. So the purpose of this talk is to give you an insight into orthopaedics that you can't get from an elective by itself. The fact you tuned in today shows that you are interested to some degree, and this isn't really surprising as many students do quickly start to see the appeal of orthopedic surgery. Orthopedic surgery, sort of the responsibility of relieving patients of their disability, it's not too far removed from the sort of public's archetypal view of what medicine is all about. And so what often draws students to orthopedics, or draws students to medicine in the first place, often goes on to draw them into orthopedics after. There's a huge range of procedures you can perform, cases you see, and the kind of patients you'll treat. And this variety is what makes the career so interesting, and it's a key to longevity in any career to have variety. A unique draw to orthopedics is that some of the procedures you perform lead to immediate, tangible, and positive results. The problems patients come in with are debilitating, but after a variable period of recovery, they do leave you happy. That is sort of an oversimplification, but compared to other surgical specialties, patients tend to be healthy and they tend to do very well. In addition, you're also directly treating the pathology rather than simply managing it as you would in, say, heart failure. And this is what makes the work extremely gratifying, and patients are usually very thankful to you. The patients can also range from a professional athlete who helped get back onto the field, or it could also be giving someone's grandmother the ability to live independently again after a hip replacement. And the work's varied. The term orthopedics is derived from literally the word straight child, hinting at the importance of pediatrics in childhood injuries and the development of the subspecialty. But pediatrics isn't the only subspecialty of orthopedics, obviously. Procedures will involve the entire MSK system, not just the bones. And so you'll also be working on restoring function to ligaments, tendons, and more rarely peripheral nerves. The surgeries you do can be classified in many ways, such as dealing with fractures of bone versus injury to soft tissue. There's trauma versus elective surgery. There's arthroscopic and minimally invasive surgery. But orthopedics also has kept the large open surgeries that have sort of become a rarity in the age of laparoscopic surgery. And then there's also adults and pediatric. The surgeries you can do can also be based on anatomical region, such as focusing on hand, lower limb, or spine. This huge variety of work is reflected in orthopedics being one of the largest surgical specialties. And whilst there's certainly opportunity to specialize, most orthopods will have an on-call rota to cover a trauma workload. On-call work is taxing, but it also does offer the excitement of accident and emergency. Where you'll be dealing with emergency cases, most often these are road traffic accidents. Again, there's a huge variety in the ways people can break their bones, so you won't get bored of finding ways of fixing them. Also within each rabbit hole of subspecialization, there's subspecialization. We can end up working alongside surgeons who have trained from different surgical specialties. For example, neurosurgery and orthopedics can share spine and peripheral nerve surgery, but here orthopedics will focus more on deformities, whilst neurosurgery can operate on the spinal cord. And orthopedics and plastics can also collaborate in delicate hand surgery. And then your major trauma cases can involve every kind of surgeon. So that might include orthopedics, vascular, general, and cardiothoracics all working as a team and together. Note that if you are interested in the trauma side of orthopedics, the US and South Africa are great places to do a fellowship. And that's just because over there, trauma is a specialty in and of itself, whether in the UK and Ireland, trauma and orthopedics is combined together. So how to become an orthopedic surgeon? In its most basic core steps, you do intern year, VST for 2 years, you do your surgical exams, your higher surgical training, and then you pass your fellowship exams. Once you do all of that, you'll get your certificate of completion of surgical training, and then you'll be called a surgical specialist registrar. It is at that stage you'll swap your title from doctor to Mr. or Mrs. in recognition of your achievement. At this stage, you can then also apply for consultant positions. From that table alone, or that flow chart, it might seem it might only take about 9 years after medical school that you'll become a consultant surgeon. However, it will almost certainly take longer than this, and your career pathway might look something a bit more like that. What I want to sort of communicate by this is it is going to take a long while to become a surgeon, and it's also very competitive at each stage. So never get discouraged if you apply for a training post and you don't get it first try. But the key is perseverance and to develop your CV through taking time out to do what's called out of program training. This can include stuff like an MD or a PhD, or it can also include a fellowship. And yeah, so the take home point is it's going to be hard work and it's going to take a long time, but try and enjoy the stage at here and now. Anecdotally, I've heard that zipping through training as you do in, say, the top flow chart, some people view that as the best way of doing things, but also it's very hard to justify taking career breaks such as doing Australia, doing MSF, or doing fellowship if once you complete training, because those career breaks are much harder to justify once you're a consultant. So what can I do now to get ahead in surgery? So a great thing about medicine in general, not just surgery, and compared to, say, business or creative arts, is your career progression is really well defined. And when you come to these interviews, you have tangible goals to aim towards. And so even if you never applied to the UK, a really good UK resource I found was the NHS Self-Assessment Guide to Core Surgical Training, a section of which you can see in the slide. Even if you have no intentions of applying to the UK, this is a really good resource to look at because it gives you a framework of what you can do in your extracurricular activities to do alongside of your degree. So showing that I've got achievements and prizes, this can be something you get from university, or another good thing to do is essays. So the take-home point here is try and work on extracurricular activities. There's a temptation to study 8 hours a day, and that might get you a first. But if you take the riskier decision to apply for a national essay competition and you win that, even if that means you get a 2-1, if you win a national essay competition, you get 5 points, as you can see in that. So do try and take the time to go for your extracurricular activities, go for essay competitions, and try and look at that self-assessment guide to see what's good and what's weighed heavily for. Another important aspect of a surgical CV is not to forget the paradigm of publish or perish. And what this means is get involved with research and audit. It's definitely easier to get involved with research if you're working as a doctor, but if you can get involved as a student, it gives you an edge for 3 reasons. 1, it demonstrates an early interest in surgery. 2, it gives you a cumulative advantage if you want to get involved in further research when you do start to work. And 3, it can take off the pressure of getting that research tick box, and then you can focus on other aspects of your CV when you are a doctor, such as passing your surgical exams. For research, a really good starting point is to ask a consultant you get on well with if they have any research ideas or projects you could get involved with. Not every consultant will be receptive to this, but don't let this put you off asking others. And because sometimes a surgeon will be really happy to help out an enthusiastic student and let them do some of the legwork for a research project they have. Likewise, audits can be really high yield for not too much effort if you select the right one. The key here is not to be too overambitious and keep it relatively simple. If you've already done part of an audit, it's really worth going the extra mile and doing something like a presentation or develop a guideline based off the audit. And then if you re-audit that again, you can show that the presentation you did or the guideline you did had a positive impact, and people love this in interviews. So if there's one thing to focus for, like really focus on, is doing the audits and quality improvement. For any ideas on audits, again, like research, ask your consultant if there's anything topical in their department they're working at, or there's some online resources such as NHS Scotland's audit book. Other aspects of a well-rounded CV will include areas such as teaching, leadership, and presentations. So what kind of stuff do you do once you're a consultant surgeon? Consultant orthopedics will have duties in addition to surgery, and this can include outpatient clinic, administration, teaching, and research. That being said, in a typical week, about 40% of your time will be spent in theatre, and then the rest will be spent in those other duties, and a lot of that will be in clinic. The thing about clinic is it is an essential part of the job, not just for patient follow-up, but also the select which patients need a surgical intervention, which can be managed conservatively. The balance between theatre and clinic can vary between subspecialties, and some may prefer the slower pace of outpatients. For example, orthopods specialised in foot and ankle will have far more time spent in clinic than in surgery. This is just simply a reflection that many foot pathologies are managed non-operatively, and whilst others might focus on trauma where more time is spent in theatre. So some of the, I've got a quick just intro of some of the common procedures orthopedic surgeons do. So there's arthroscopy. This is a form of minimally invasive surgery, only instead of within the space of an abdominal cavity, you're within the confines of a joint space. It's used extensively in knee surgery and ACL repair, and also mastectomy. And if you're a knee surgeon, arthroscopy would be a bread and butter procedure for you. So a lot of your workload would be with scopes. There's fusion surgery. So this can either be done with a bone graft or screws. The surgeon immobilizes a joint, and over time, as the name suggests, the bones will fuse together. It's often used as a last resort procedure in treating arthritis in small joints, but it can also be used in spinal pathologies. There's then internal fixation or fixation of any kind. This is the bread and butter of managing trauma cases. This can include plates and screws, which are the most invasive, but also the most stable. Intramedullary nails, which can be used in long bones, and then K-wires, which are a little similar to nails, but just a lot smaller and for smaller bones. If in severe open fractures where the skin's compromised, external fixation is preferred, as this decreases the risk of infection in an already vulnerable injury. External fixation, such as Lazarov external fixator, that's the one you can see of the rings. That's often used as a bridging procedure for more definitive management, the more definitive management being the internal screws and plates. And then, yeah, there's arthroplasty. So this is basically the word for joint replacement. A huge portion of arthroplasty workload is in arthritis, but the procedure is also used in a lot of trauma. The most common site arthroplasty is done is on the hips, but you can also occasionally see it on the shoulders, fingers, and occasionally the ankle. There's osteotomy. This is just removing a small piece of bone, and in orthopedics, this is usually done to improve a joint alignment and say if there was an arthritic pain, or it's also used in pediatric bone deformities. And then I have lastly soft tissue repair. Here it's a really broad term, but it encompasses any procedure that's focused on ligaments and tendons. Sports orthopedics will also be focused on soft tissue repair. Soft tissue procedures specifically could be acute injuries such as a torn rotator cuff, or it could be overuse injuries such as Achilles tendinopathy, which may require surgical management. Yeah, so now onto the subspecialties. So starting off, there's pediatric orthopedics. And whilst this field is limited to children, it has one of the biggest ranges of procedures you can perform and diseases you will manage. Due to the fact that children are still growing, surgeons have to be really careful and selective when they do surgery, just owing to the fact that they have growing growth plates.